Hi, I'm Marybeth Gilliam, and this is the Outperform Cancer podcast, where we discuss actionable anti-cancer strategies found in peer-reviewed scientific research. Historically, cancer treatment has been determined by its address, meaning where the cancer appeared in the body, lung, prostate, blood, or whatever body part. But that's a little bit like identifying someone by their zip code. It tells you something, but it certainly doesn't tell you who they are. Biomarker-driven care is more like using fingerprints. It looks at the unique biological features of that individual tumor to help determine what treatment is the most likely to work. And when scientists and physicians can match highly targeted treatments with a patient's extremely specific biomarkers, the results can sometimes be extraordinary. In this episode, our guest, Dr. Nathan Fowler, shares a remarkable story about an advanced patient that he had whose life was transformed by exactly that kind of approach. That's why this conversation is so important. Cancer patients are increasingly hearing terms like precision oncology, tumor sequencing, molecular profiling, and biomarker testing. These terms may sound complex, but the idea behind them isn't. The more we understand the biology of a tumor, the better chance we have of matching a patient to the right treatment. This is not future science. This is now science. This is available to you today. And yet, this approach is radically underused. A 2025 JAMA Network open study found that only 35% of more than 26,000 patients with advanced cancer had evidence of molecular biomarker testing before starting first-line treatment. That's especially notable because biomarker-guided approaches have shown much stronger results than non-personalized treatment strategies in research settings. In a meta-analysis of 351 phase 1 studies involving more than 13,000 patients, trials using a personalized biomarker-guided approach had a median response rate of 31%. This compares with only 5% in trials that did not use biomarkers to guide treatment. Now consider a separate study by the American Cancer Society which found biomarker testing rates higher amongst those with higher education and income levels. This is why I publish these episodes. This is an important anti-cancer strategy that can have dramatic effects on cancer outcomes, including survival. And it's available to everyone. But as patients, we need to understand it and we need to ask for it. So, to better help us understand biomarker testing in precision medicine, I am joined by Dr. Nathan Fowler, Chief Medical Officer at BostonGene and former Professor of Medicine at the University of Texas MD Anderson Cancer Center. At MD Anderson, Dr. Fowler focused on developing innovative new therapies and led clinical research and new drug development programs for nearly a decade. Today, he brings more than 20 years of patient care experience to BostonGene, where he helps guide efforts to use advanced data and precision medicine to identify more effective therapies for cancer patients. In this episode, we'll talk about what tumor sequencing can reveal, how it differs from inherited genetic testing, what patients and physicians can do with the information, and why biomarker-driven care may be one of the most important shifts in modern oncology. Join me in welcoming Dr. Nathan Fowler. Dr. Fowler, thank you so much for joining us today. We're really excited to talk to you.
Thanks, Marybeth. It's great to be here.
So, we're going to talk about one of the most important shifts in modern oncology, moving from a one-size-fits-all treatment towards personalized medicine. And I know that's something that's a continuum and that has already started, but new technology is really changing that playing field. And I'm hoping that you can talk to us a little bit more about what that looks like today and help us with the terms that cancer patients are hearing right now, like precision oncology, genomic testing, molecular profiling, tumor sequencing. Like they're hearing a lot of terms, and we would love for you to set up for us what does personalized medicine look like today, and how do biomarkers fit into that?
Sure. So, the sad state of affairs is that we don't use 90% of the information that we understand about patients' tumors. And I remember, I used to describe how we treat patients. We have the ability to look so deeply at what drives a patient's cancer. We can look at it literally at a molecular level and understand the genes. We can understand the mutations that drive a cancer. And why is that important? Because those are the things, if we can identify them, that make that cancer vulnerable. The problem today is that, we have all these sophisticated tools, but the way we treat patients is still based upon really the size, the shape, and the location of the tumor, which is ridiculous. This is technology that is decades old. Really, think about how we treat people. We treat people based upon the fact they have a breast cancer, it's bigger than 2 centimeters, and maybe it's spread or it hasn't spread. But we understand that there are key differences in tumors that may be the exact same size, exact same shape, and exact same location that can help us, better understand how to cure a patient. And this is where you kind of talked about precision medicine. You could argue that, we've had somewhat, uh, you know, precision medicine advances in the past, treating patients based upon the hormone status, but we can go so much deeper. So when I think about precision medicine, I want to know, kind of what are the key drivers in that patient's cancer that I can use to target them with a new drug. Because that's where we're really going to see, these major breakthroughs and hopefully cures, especially in folks where maybe traditional things haven't worked so far.
Can you give me an example of where you've seen that be successful? I
Sure.
know, you've had a whole career as an oncologist
Yeah.
before you even went to Boston Gene. When have you seen this be really revolutionary in terms of patient outcomes, changing patient outcomes?
I'll give you a great example. This was an older gentleman that I was treating. It was probably 10 years ago. And he had a lymphoma. It was not a very good lymphoma. I mean, no lymphomas are good, but this was an especially bad lymphoma. It was in his leg. It was in his right leg, and it was so bad that he had lost the ability to walk. It was, growing, and we had to do a lot of bandages of the leg. And I started him on a therapy at the time, which was experimental. This was a therapy targeting a marker on the surface of his tumor called CD30. It was at that time, an experimental drug. I put him on a phase 1 study with this agent, and lo and behold, everything started to go away in his leg. In fact, I first thought that potentially this was the tumor getting worse because he was having some, changes in the bandages more often. And I was fooled. What was happening was that tumor was actually melting away.
Wow.
And I continued to give him treatment, another, 2 weeks, 3 weeks, 4 weeks, and eventually the skin all cleared up. All the scans became clear, and he went into a complete remission and is still in remission now a decade later. This
Wow.
gentleman had failed chemotherapy. I had done radiation on his leg. He had a thing called T-cell lymphoma, which is fairly rare, and he was cured. And and the reason why that cure worked is because this was a marker that was unique to his tumor. It was a marker that was associated with a drug at that time, which was experimental. And when I combined the two, again, the presence of that biomarker and a drug that targeted it, I cured him. When when I say I cured him, sorry, the drug cured him.
Sure.
I was just the vehicle. But and I can tell you, I've had so many examples in my own career where we found a unique marker in a patient, in the patient's tumor, I should say, we were able to link that with a drug that was, unique to that marker or that driver or that pathway, and patients went into remission when nothing else was working, including patients who had had things like stem cell transplant and radiation and surgery. So it it just drives me nuts as a guy who sees these folks or used to see these folks on a regular basis, and a lot of them are not even getting tested. To me, it's one of the biggest misses today that
Mhm.
we have in oncology is not even knowing
Right.
what biomarker exists in a patient's tumor. It's
So, I'm always trying to help cancer patients help themselves.
yeah,
I'll tell you a little story about when I was diagnosed in 2020. I was reading about biomarker testing and
yeah,
I insisted I wanted to have my tumor sequenced, fully sequenced. And so I had known that they had only done a core needle biopsy, so there wasn't a ton of tumor, and it was sent off to get done. I kept
yeah,
saying, "We might not have enough. Shouldn't we check? Do we see enough before we got to take all this treatment? And then if the treatment works, then no more, no more sample." Which
sure,
and ultimately, that's exactly what happened. They got back to me instead of with results in 3 months with the news that there wasn't enough tumor for testing, which
yeah, yeah,
was very sad. But my oncologist at the time said, "Well, it's not a problem. We'll just test it when the cancer comes back." Now, from a patient perspective, my hope is that we can use this proactively,
yeah, sure,
not reactively. And so, can you just help me with, as a cancer patient, what does a cancer patient need to ask for? And when should they be asking for these tests? Should they only be asking for it after there's a recurrence of metastatic disease? Or should you be asking for it even if you're a stage one, cancer patient, maybe a lung cancer patient or an early prostate cancer patient?
yeah.
Who needs biomarker testing?
So it's a bit of a loaded question. I mean, I am biased. I think everybody should have biomarker testing as soon as they're diagnosed. We know from, actually lots of studies that treatment tends to work best if it's used earlier, the appropriate treatment. These diseases, unfortunately, they don't have a brain, so they don't get smarter, but they can evolve. They can develop resistant pathways. Sometimes they become heterogeneous. That means that the tumor actually begins to morph, so it has several types of tumor within the same tumor. The earlier you can treat it, and think of this as an analogy as a newborn, it's most susceptible when it's first developed, because that's when it's fairly naive, and if you can find the right target and hit it, many times you can cure it. I'm a big believer that all patients should have biomarker testing early. Unfortunately, the state of medicine today in most parts of the world, including the United States, is that biomarker testing is only reimbursed. It's only kind of in guidelines once patients develop either metastatic or advanced disease. And I think many times that's probably too late. Not necessarily to identify a treatment, but I don't want to treat people. I want to cure folks.
Yes.
And I think
Everybody
that
wants to hear that.
yes, and I always think the best opportunity isn't in that first round of treatment.
Yes.
Um, so that's a long answer to your short question, but I think that everybody should have biomarker testing as soon as possible. The good news is that today there is I think a greater recognition that biomarker testing could have impact earlier in the disease, and so I think that both because of patient advocacy, because of work by large academic groups, this is happening more and more often. Still not enough, but definitely more than we probably saw about 10 years ago.
Yeah, I have seen actually some statistics that I looked up in getting ready for our
Yeah.
conversation. One of them came from a 2025 JAMA Network open study that
Okay.
said only about 35% of the more than 26,000 advanced cancer patients in the US are
Yeah.
receiving biomarker testing to guide treatment. So it is a very, in my opinion, low number.
Yep. For
Mm.
sure. And I would be willing to bet that those patients are probably pocketed in areas where they're being seen in an academic center, or where they were, the patient was educated enough to ask for it.
Yes.
But that's a number we definitely need to get. get higher.
We need to get higher. So let's start with the patient. How does a patient ask for biomarker testing? There's a lot of words being thrown out there. Do they call it tumor sequencing? Do they
Yeah.
sometimes there's blood, testing, liquid biopsy testing versus tumor testing. Can you talk about the different ways that someone can be tested
Yeah.
and what do they ask for?
So honestly, as a treating physician, even just asking for biomarker testing, just those words alone will trigger something in your treating physician to say, are you doing biomarker testing? And honestly, I would ask the physician, what does that mean? Because again, that's going to stimulate that physician to start thinking about, okay, well, what does that mean? Because it's a very broad definition. So I would put it back on the physician, honestly, and it's not threatening to say, "Are you doing biomarker testing in my tumor?" Hopefully, that question is, "Yes, of course I am." Oh,
Mhm.
right. What? Tell me what that. Could you tell me what kind of testing um, that is, and what do you plan on doing with it? Open-ended questions, because most physicians, like me, we obviously want to do best by the patient,
Of course.
but sometimes challenging the physician is the best way to get them to act. Uh, and when I say challenging, not in a threatening way, but to say, "Are you doing biomarker testing? And what testing is that? And how are you planning on using that?"
Mhm.
I can't think of many physicians that wouldn't actually enjoy that kind of conversation.
So,
In other
if
words, I don't think you need to say, "Are you doing whole transcriptome or whole genome sequencing?" Because that, in my opinion, will put the physician a little bit on the defensive because
okay,
uh, instead make it broad.
make it broad. I think that's a great step forward and something that is not hard for patients to
Yeah.
do, right? That's a very easy thing. We can all do that. One of the questions I get from patients is, okay, there seems to be a lot of different kinds of tests. How do I know what's right for me? Are there certain tests that are better for a new diagnosis versus a recurrence, for example?
Of course, I'm a little biased because I work for a company and we do have our own tests that, at BostonGene, we developed a fairly broad test. We call it a comprehensive tumor sequencing or a comprehensive panel. And there we're doing pretty much every biomarker that is currently standard of care, as well as things that are still in the pipeline. And so, again, we're very interested in looking at everything that's happening within the DNA of that tumor. That's called whole exome sequencing. We look at the entire RNA profile. That's called a whole exome or a whole transcriptome. But then we're also looking at kind of the background microenvironment, what's happening in the patient's immunity. We're understanding, are there germline or inherited things that may be happening with that patient? There are several tests like that in the market. So the good news is that I think, unlike 5, 10 years ago, where I think most physicians, when they thought about panel testing, it was a fairly limited or small panel. And the good news, again, is that more comprehensive sequencing, comprehensive panels are slowly being adopted. So
Mhm.
again, if you wanted to advocate, I would absolutely advocate for a comprehensive panel test.
Mhm.
I think BostonGene is a great option, but there I think some physicians may have their own bias, or they may be tests that they work with on a regular basis. So I think a comprehensive test is absolutely the best thing that they can have now, not only because it will inform treatment decisions now, but a lot of that information could be used, God forbid, if the patient relapses or if they become resistant to the therapy that's prescribed.
That has been the case for patients that
Yeah,
I've met. And I want to ask you a follow up on that, which is if I was tested when I was originally diagnosed,
yeah.
and let's say a few years go by, and there's a recurrence. Do I need to be tested again?
I would like people to have any testing. Now, ideally, it's good to have a repeat test, especially if there's been therapy that happened in the interim. Um, we know that therapy can drive different pathways. It can drive resistance, so that the tumor can change as it tries to evade treatment. Now, let's say that a patient had a limited stage, meaning it was just one lump somewhere. That lump was taken out. 6 months go by, a year goes by, and they find a second lump. Honestly, I'm not sure if there's a lot of benefit of getting another test because it's probably the same disease that was present at that first diagnosis.
Mhm.
Now, that the opposite end of that would be a patient had a initial disease, went through a couple rounds of treatment. 3 years later, the disease is again coming back. There, because of both the time and the exposure to treatment, I think a secondary test would be warranted because there could be changes. It's not as exactly a straight answer. I think it depends on the time and the exposure to treatment.
No, I think that makes tons of sense. I think,
Yeah.
what I'm hearing you say is that, when you have had actual treatment, um, w where something could develop a resistance,
Yeah.
or could mutate, what we'd wanna see is, okay, if there was a mutation, maybe there's a new drug that could target
Exactly.
that new mutation, and we wouldn't know unless we had a new test.
Or, one of those findings that was in that first tumor is no longer there. And so even worse is, the doctor makes a decision based upon that first test and it doesn't work. So not only new targets, but sometimes the targets that were there before have kind of morphed. So we're doing I think, a really cool study with MD Anderson, and there we're asking that very specific question. In patients who had initial genetic testing and had treatment, if we rebiopsy them, how often does that biopsy change?
Oh,
So
I can't
we'll
wait
have
to hear
real.
those
Oh
results.
yeah, I'm super excited. It's a doctor called Dr. Fundameric, who's a brilliant phase 1 researcher who's kind of building that study. But that's the exact question. How often does it change, and how often do we change therapy?
Mhm.
Understanding that new knowledge.
So, what happens if a patient doesn't have a tumor sample,
Yeah,
for one reason or another? It's really hard to get at. Maybe it's a glioblastoma, or
sure,
maybe it's something else that's hard to get to. Maybe
yeah,
something in the lung. Can that patient do anything? Can they get biomarker
absolutely.
testing?
Yeah, no, absolutely. There are lots of tests now that can actually look at some of these changes, or some of these changes in the tumor, and we can see that in the blood. So now there are several tests available where we do what's called a liquid biopsy. That's a fancy word for blood test, where we can actually see some of these changes, both in the DNA and the RNA in the tumor in the blood. So first option, I think, for me is always to look directly at the tissue because we can see what's happening at that level. But in cases, as you mentioned, where that's not available, blood is becoming better at reflecting those same changes.
We talk a lot about the tumor microenvironment these
Mm,
days, and on how that environment can actually influence how the mutations respond. And
yes.
I'm wondering, if you do you only get the information on the tumor microenvironment if you have a tumor tissue sample, or do you get that information with a liquid biopsy as well?
It's a really cool question. So think about the microenvironment is anything in the tumor that's not tumor. When a person develops cancer, the immune system will recognize something's wrong. And the immune system will send a whole army of little cells to try to kill off that tumor. So within that tumor, there's lots of immune things called T cells and NK cells and B cells. So these are our body's own defense that is now infiltrating into the tumor, trying to kill it. That's what we call the microenvironment. In addition to those cells, there's like skeleton framework. Think about it like structure these are kind of support cells. All those cells make up the microenvironment. But those immune cells, they weren't born in the tumor. They're coming from the blood or the bone marrow or the spleen. So we can pick up those signals by looking at the blood. So we can see these little cells actually trafficking, moving to the tumor or moving away from the tumor. And now they've been changed. They've been triggered. So they have little receptors that are now saying, I'm looking for the tumor. I'm looking for. So we can pick up those changes in the blood. It's a really
That's
cool. I
amazing.
think it's cool. Oh, it's phenomenal. I think I'm kind of nerdy about these things, but so you can pick up not only changes and picking up little pieces of DNA that are coming from the tumor, but you can also see these changes in this army of our own immune cells that are reacting to the tumor. And we can then kind of make a lot of inferences around what's happening at the tumor level without actually getting a biopsy.
Wow.
This is really emerging science right now, and which makes sense, right? Nothing in our body is happening in a vacuum. Anytime we see something that's happening in a tumor, it's probably also reflected in changes in the blood.
Yeah.
So it's um, yeah, it's really exciting to be able to kind of see these changes happening, and you can monitor it real time.
Wow.
Because if you again, if a patient gets treatment, we can monitor the blood at multiple time points and actually see how a patient's immune system is reacting to that tumor or reacting to a drug. For example, you mentioned if a patient gets a drug, we can see is the drug working? Is the drug maybe triggering a immune reaction like a vaccine that is
Wow.
now trying to kill the tumor?
Let's say I'm a patient and I have started a new therapy, and the therapy is going, and I've got 6 weeks in, and I want to know if it's working. Currently, I would get a scan to see if are things
Sure,
shrinking or not shrinking. But
sure.
that doesn't tell me are immune cells traveling to have I stimulated my immune system? Like it's not telling me a lot of the information that you just told me. So
Correct.
my question is, do I ask for biomarker testing at that point or is that a different ask?
So there's a couple different ways that we can monitor tumor response outside of a scan. The one that is probably most common today is called cell-free DNA. This is where we're looking at levels of remember the tumor as it multiplies or as those cells divide or as they're killed, they release little pieces of DNA. And we can do something as simple as just monitor the level of those DNA fragments in the blood. If they're going up, it probably is not good, or it means that the patient has an early response. And if they're dropping or if they go away completely, that means the tumor is probably responding. Now, unfortunately, some tumors don't shed a lot of DNA, or the DNA that is coming from the tumor, we sometimes have a hard time recognizing that from normal because every cell in our body is releasing some DNA. And so what we're looking in, literally, a kind of or sorry, figuratively, is a needle and haystack. We're looking at that very specific DNA that's unique to that patient's tumor, and is it going up or down? So that's again, a technology that is probably most commonly used. We call that MRD or minimal residual disease, right? This is small DNA fragments. So if a patient is asking their physician, I would say, are you doing cell-free DNA or MRD testing in my tumor?
Is that the same as ctDNA?
Yeah.
Okay.
Cell-free or ctDNA. This is DNA coming from the tumor. ctDNA sometimes, or cell-free DNA is referring to whether or not the DNA is still within the cell or it's free floating. But it's the same concept. We're looking at DNA levels in the blood that are reflective of something happening in the tumor. Now, what you alluded to is a bit different. This is where we're monitoring immune response. Those things, ideally, and usually they will correlate. Immune response, if the drug is working, should be reflected in a drop in the cell-free or ctDNA, but not always. I mean, sometimes we'll see kind of preclinical changes. So our immune system, it's such a wonderful thing that we're born with. It's extremely sensitive. We can actually pick up very, very small changes in T cells, probably even before the tumor begins to die. Our immune cells, they can pick up even the slightest change in the body. Our immune system is constantly monitoring for COVID, for viruses, for bacteria. Think about your immune system. It can recognize a teeny tiny infection somewhere in your elbow and actually mount a response.
Right.
It doesn't require a big, 3 centimeter tumor to understand something's wrong and mount a response. So ideally, we should be able to pick up these very small changes in immune populations way before we actually see something changing on a CAT scan, or potentially even before we see changes in cell-free DNA. Now, those things are still kind of in the pipeline. This is something our company has been focused on for the last couple of years. I don't think that it's quite standard of care yet, but stay tuned. Those things are coming.
Stay tuned. And as a patient, I always encourage ask. You never
Yes.
know what you can get unless you ask.
Yeah, there are lots of trials that we're doing to try to show that this actually works.
Mhm.
we're working with a phenomenal group called the Parker Institute for Cancer Immunotherapy at PICE, where we're doing lots of studies to understand how this immune monitoring could reflect actual response in patients' tumors.
That's amazing. Yeah,
Yeah, it's
super
super,
amazing.
super. I
Yeah.
I get so excited when I think about how, because ideally, we'll be able to do these things with a very simple blood draw
Mhm.
in your doctor's office. No, CAT scans and MRIs and waiting in line and contrast and drinking nasty fluids. Just a simple blood test will be able to monitor a lot of this stuff. And this is real time. This isn't science fiction. This is coming very soon.
Coming soon. Yeah, I'm so excited because, so many things that we have to do to our bodies when we've been diagnosed with cancer has such negative effects on other parts of our bodies.
I know
I'm
it's
got neuropathy in my feet from one of the drugs. And, so being able to not get PET scans regularly is, that's a goal. That's a goal. That's a
it's
goal.
just it's we have this really terrible joke that we try to kill the cancer before we kill the patient.
Yeah, right,
Because it's, just the toxins and the radiation exposure and all the things we do to patients as we're fighting this disease, uh, has a real cost,
right.
and
It
quality
does.
of life. And so I fully understand that as one of the perpetrators of those effects, unfortunately, uh, I don't take it lightly that
I know
we
you
can make
don't.
patients really sick.
Yeah, I know you don't. And one of the great things is that when we have biomarker driven care,
Yeah.
where we have done the testing, we understand the mutations, maybe we even understand a little bit about the T cells and our immune response, then we can get targeted therapy. And those targeted therapies have less side effects,
Oh my
right?
gosh, yes. So think about, the way we traditionally have treated cancers over the past, gosh, probably almost 100 years now, is that we basically just look for cells that are dividing. Most of the treatments that we develop, things like platinums, they're basically just looking at any cell that's trying to divide, making new DNA, and we interrupt that cycle. And, cancer tends to divide more rapidly than other types of cells in our body. But there's lots of other cells that also divide pretty rapidly. Hair,
Yeah,
GI tract, skin. Why are the side effects? Bone marrow. Fairly specific. Actually, they're not specific. They're just any cell that's rapidly dividing in our body gets hit with standard chemotherapy. Thank goodness, we've gotten a lot smarter. Uh, well, I shouldn't say that. We haven't gotten smarter. Technology has gotten better.
hmm,
um, at identifying unique vulnerabilities that are specific to a cancer cell and not to a normal cell. That's the key factor, right? I want to find something that is unique, and this is tough because cancer is coming from our own body.
right.
So if I'm thinking about a lung cancer, I need to find something that is in the bad lung cells, the tumor cells, but not in normal lung, and that is tougher than it sounds,
Yeah,
because we have to find as that cell changes, what things that changed can I target with a new drug that are not in the old version of that same cell.
right.
And but we're definitely getting better at it. And as I mentioned, I wish I could say, as doctors, we're getting so much better, but a lot of it's just technology. We have better science. We can sequence patients. We can look at a lot of these key details in a much more specific way than
Mhm.
we were 20 years ago.
So I want to talk about application for a
Yeah,
minute. A lot of cancers are defined by body part, right?
sure.
So it's a
Yeah,
breast cancer, it's a lung cancer, it's a brain cancer. Um, but we know that through sequencing, sometimes there's a mutation that you don't expect. You might expect
yeah,
it in a lung cancer, but it
yeah,
shows up in a breast cancer. And I'll just, for example purposes, say something called EGFR.
yeah.
EGFR, I believe, is often associated with lung cancer. What happens if it shows up in a breast cancer? Would a breast cancer patient then be eligible, theoretically, of course, for the drug that
Sure.
targets EGFR even though it's technically a lung cancer drug?
In the past, no. When I say eligible, what I mean by eligible, is it FDA approved in another setting? In general, no. So most drugs are approved in the past based upon what you said, the location of the tumor. Um, when I say location, I'm talking about usually the way we define a tumor is the organ that it came from. Now, most recently, actually just in the last couple of years, we began to see approvals of drugs not based on location, but based on the biomarker. Certain fusions, certain mutations. Um, the FDA acknowledged that we are going to approve this drug. I don't care where the tumor is or where it came from. If you have this marker, you can get the drug. Of course, you can get the drug no matter what, but often what it means when a patient has, or sorry, when a drug is FDA approved, it means that that drug will be reimbursed and available. So that, again, thank goodness, is changing. We're now seeing drugs that are approved based on the biomarker, agnostic of the diagnosis. Thank goodness. EGFR is not one of those today. That potentially could change in the future, but most of the older meaning 10 years ago, even 5 years ago, drugs that were approved based on a single target, a biomarker, a pathway, were disease specific. And in order to get that drug, the physician generally has to apply to hospital formularies or get it on compassionate use from a drug company.
So you're saying, just to recap a little bit,
Yeah.
what you're saying is um, coming soon, that there are some cases where a drug has been approved for various
Right.
organs, not
Right.
just the single source organ that it was originally developed or tested on. But that isn't broadly the case yet, but we're
It's not.
moving in that direction.
We are moving in that direction now. Um, what I didn't want to allude to is that um, is off-label use of a drug. In general, we tend to uh, advocate for drugs that are FDA approved because those drugs we know have been tested, they're safe. All drugs are associated with some side effect. And so it's always a balancing act between trying to, use something that will help a patient, but also mitigating risk. Now, as patients move into, unfortunately, sometimes as the disease progresses, we run out of options. Doctors are a lot more willing to use what we call off-label therapy.
Mhm.
But I always get a little nervous. For example, you mentioned EGFR. If I found EGFR in a woman with early stage breast cancer, would I use that instead of standard treatment?
Mm.
Probably wouldn't, because standard treatment has a good chance of a cure. Now, if that same woman, had a treatment, a second treatment, I begin running out of options, I'm absolutely willing to consider using EGFR either on compassionate use or applying to a company because standard things haven't worked. So I just want to be very clear.
Yeah, that's
Although,
helpful.
yeah, and I think that biomarker testing is extremely relevant. Sometimes we find things, as you mentioned, that help maybe even change the diagnosis we would have, it prevents us from using the wrong treatment. But I think we still have to be careful about using a targeted drug in lieu of a very effective regimen in settings where a cure is possible with the
Mhm.
standard. As boring and as yucky as that standard regimen is, at the end of the day, my goal is to cure,
Of
uh,
course.
not
Yeah.
to try to use the best treatment or not to try to use an experimental treatment just because I can. So it's again a balancing act. This is why you mentioned it earlier. It's so important to have a true partnership with the physician, to have mutual trust, and actually, I shouldn't say this, but and change your doctor if you don't have it,
Yeah. Yeah,
because
I
they
try to
should be your biggest advocate. Yeah,
they should, and try to, help advocates see that so help patients see that you don't have to walk away from anybody. You can build a bigger care team. So, more smart people thinking about your case is
hundred
not a
percent,
bad idea.
100%.
So, go to MD Anderson, Dana-Farber, some of the, larger centers or larger academic centers, University of Pittsburgh,
Mhm.
and just try to build out a care team because, you know, individual oncologists, they like to have other people to bounce ideas off of too.
100%.
Would you want to be solely responsible for all these people's lives on your shoulders all the time and you don't get to talk to anybody else? That
I love it.
sounds daunting to me.
And most of us are trained in that way. I mean, most of us were trained in a setting where we would meet for grand rounds, we'd meet for morning reports, where we would go over cases together and we form consensus. So, yeah, as you mentioned, I was at MD Anderson, which is a very large referral center, and if patients would tell me, "I wanna get a second opinion," I would be I love that. Are you kidding me? Why would I not want someone else to give me input? If the goal is to help the patient, I want as many people thinking about that as possible. So
Yeah,
I completely agree. I
I
completely agree.
I love it. I want to go back to application because,
Yeah,
again, so many patients are trying to navigate a path forward and they just don't know how to take a step. And so you had started off talking about a really cool case where you
yeah,
actually cured a patient. And you mentioned that there was a phase 1 experimental drug that you paired him with because
yeah,
of the biomarker testing that he had. What
correct.
I want to know is, what does this mean for clinical trials today? Like, if I get biomarker testing, do more possibilities open up to me, and how do I know what those are? How do
100.
I get that in your report?
Yes. So in the BostonGene report, we pretty much list every biomarker that would be associated with the therapy, either standard of care or something that is that currently exists as part of a phase 1 or phase 2 or phase 3 trial. At MD Anderson, for example, we work with an internal team there that will link patients looking at their biomarker findings and studies that actually have openings for biomarker directed care. I think that in large academic centers, especially in Houston, on the East Coast, and other places, that should be happening routinely. So if the patient has a comprehensive test, the care team should be looking at that test and understanding if there are available treatment options. In some centers, that is not always happening. So I do think it's important to advocate to say, especially in patients who have maybe received 1 or 2 prior lines of treatment. Say, what are my treatment options within the context of a trial, and how will you understand if I'm eligible? Should I be getting genetic testing? Again, I love framing these discussions in the form of a question in the physician. Because as someone who did this for nearly 2 decades, I saw many patients who were coming in to see me as a second or a third opinion. And many times that's because they talked to their doctor. They said, "I want to get this test." The doctor said no. Fine, I'll come to MD Anderson. I would love to see that the physician, the treating physician, and the patient come together to me. They already have testing, and it was more of a collaboration. And so, I stay up at night thinking about, how could we have made this better for a patient where they didn't have to wait to the second or the third line or 2 years in.
It's interesting too. There are new resources that have just become available. American Cancer Society is one of the places that's making
Yeah,
them available, where a patient can contact them. You can find this on their website, and
yeah,
it's also on my website, outperformcancer.com. And you will be paired with a patient navigator who will review all of the clinical trials that
phenomenal. Yes.
that match your circumstances and your biomarkers, and they will give you a long list of what is possible. And I do want patients to also be thoughtful about asking for all available trials if you're willing to travel. So some
Yes.
people would prefer to stay local, and that is just a personal choice. That's totally okay. But sometimes medical centers are thinking about what they have to offer within their walls, and it's nice to be given the opportunity to look outside those walls
Sure.
and see all trials, because if we're trying to match a very specific biomarker to a very specific study, it could be anywhere, but it might be worth it.
Yes, no, I agree. Just getting that testing, the very first step is just to get tested.
Yeah.
That comprehensive panel testing. I just can't emphasize enough having a relationship with your physician where you work together to find the best options. Just because patients have a biomarker doesn't always mean they should be treated based on that biomarker. And I'll use a quick example. So when immunotherapy first came out, we did a lot of testing for PD-1. In many patients, forewent otherwise effective treatment to get immunotherapy. Most people don't know, but the average response rate for immunotherapy, it's 12%. So that's not great. Not saying that there are not select populations where it's phenomenal and it has cured things like metastatic melanoma. But in some diseases, checkpoint inhibitors actually caused acceleration of growth in the tumor. So there is real risk, not only real risk, but there's real side effects. So I think we have to be, this is where I'm getting at is that, when we find a biomarker, I think it's important for both the physician and the patient to have a real discussion around what's the goal of using this therapy? Is it better than the accepted standard? What are my options and what are the side effects if I go down this route?
Yes.
So I want to be very careful about, getting a test, seeing a biomarker and saying, I want this test because I have the biomarker. Because there's a lot of nuance around, what the implications of using that instead of another therapy, what are the side effects, how much is it cost, is it available, you mentioned, do I have to travel?
Hmm.
So, and why, I want to hammer on this because
Yeah.
our, our, our primary objective is to get rid of that cancer.
Yeah, absolutely.
Uh,
It's what every cancer patient wants to hear. I'm hoping you can define one more thing that I think has led to a
Talk.
lot of confusion, which is genetic testing, which someone might get to better understand any mutations they would have outside of cancer,
Yeah,
and genomic testing of looking at a tumor,
yeah,
or circulating tumor or MRD. Can you explain the difference between those things and
sure. No, it's a
why?
really good question, and you're right. It's something that I think is commonly missed because I'll ask patients have a genetic testing. They say, "Oh, I had BRCA testing, and I'm negative." I'm negative. But just a real basic lesson around cancer. So cancer comes again from one of our normal cells. All of the cells in our body have DNA that we have inherited from, our mom and dad and our grandparents, et cetera. We call that your germline DNA. This is DNA that is inherited, and it often hidden within that germline DNA often are things like BRCA mutations. And these are mutations that put us at risk for developing a primary or a secondary cancer. And we know, luckily, about a lot of these germline mutations. There are also mutations in germline that can help us understand whether or not a drug would work, if we metabolize a drug quickly or slowly. So it can give a lot of information to the doctor about your risk of cancer, potentially why you developed that cancer, as well as the type of drugs and the dose of drugs that they should use. Now, that's very different than what we call a somatic mutation. This is a mutation that occurred as the cancer was being kind of formed or developed. So this is very different than anything you inherited. You weren't born with this mutation. This happened when the cancer arose. Those mutations help us understand how to kill it. They
Okay.
don't really tell us about the risk. They don't tell us a lot about, the dose of drugs, but they tell us tell me where is that Achilles heel within the cancer that I can use as a target for a new drug. So both of them are very important, but not only kind of what they are, but how the doctor uses them are very different. And the good news is
Yes.
a lot of tests nowadays do both. So, for
Oh,
example, with BostonGene test, we do both germline testing and we do testing of the tumor at the same time.
that's great to know because a lot of people don't do genetic testing or germline testing until after they were diagnosed with cancer anyway,
Yeah.
which I would argue would be good to have, early on so you better understand your risks and if you need additional screening. I'm hoping you can just tell us a little bit about how Boston Gene is helping advance cancer treatment and drug development, because I know there's exciting things going on in your company. I know that you're using artificial intelligence to help you, and it is thrilling. So can you give us a quick summary of what's coming and what should we know
Sure.
about BostonGene?
So at BostonGene, we've been focused on developing AI platforms to look at this vast amount of RNA and DNA data that's coming from tumors. So I'll give you an example. So, you know, about, I think it was like the early 2000s, we first sequenced the human genome. This took us billions of dollars and about 14 years.
Yeah,
The good news is today we can do that exact same thing in a couple hours for less than $500.
it's amazing.
Now, although that's awesome, what it means is that we now have the ability to look at vast amounts of RNA and DNA in every single patient. Unfortunately, what most of that DNA and RNA actually means to a tumor or to a drug, we have no idea.
Hmm.
Because it's so much data, we really can't interpret it and derive meaningful kind of results with standard approaches. This is where our company is focused. We're developing AI-based platforms where we can look at a patient's entire RNA and DNA and understand what are the drivers of the cancer. How should we treat the cancer? What are the side effects that might occur when a patient gets treatment? And this is the really, if I think about all of the most promising things that AI could deliver, this is one of the most exciting, that we can interpret this vast swamp of DNA and RNA knowledge with AI and really drive home those cures. So that I think is just gives me goosebumps when I think about the potential for what we're doing.
I have so much faith in it. I really do, as I feel like just watch the progress. And I feel like it's really hard for technology to be smarter than our bodies. Our bodies are pretty darn
Yeah.
sophisticated. So if we can just understand what's happening, I think Einstein had some fabulous quote about really understanding the question and then the answer becomes, is very forthcoming. Um, and so if we can really understand what it is that we're looking at, what's happening, then I think
I
solving the equation is
you
going to be easy.
you hit the nail on the head. So really what we've been doing at Boston Gene is we build biologic models of that cancer. We call this a digital twin, where we take all this DNA, we take the RNA, we take a lot of other aspects like what's happening in the immune system, and we actually build what's called an in silico model of that tumor. I think about that movie Tron, where there's a kind of a virtual version of
Yeah.
what's actually happening in real life.
Yeah.
And once we understand that kind of key biology and we have that built, we can ask it anything. How do I kill it? How do I prevent a side effect? What's the dose of a drug? What combination should I use? But the first step is building that virtual biologic model of the tumor. And we call it a foundation model. But it's really phenomenal because once this is built and it's there already in many diseases, we can use it in so many different ways.
Uh, awesome.
Absolutely cool.
Awesome. I want to thank you so much for coming. I hope you'll come again sometime.
Oh,
I
I
know
love it.
there's
Thank
so
you,
many
Marybeth.
advances happening, but this was just a real pleasure. I think you're going to help a lot of patients, and hopefully their oncologists are ready for all the questions that'll be coming their way.
Thanks. Thanks a lot.
And now, an important announcement. All the information that was provided today was for educational purposes only. I'm a patient, just like you. I am not a licensed or accredited physician, therapist, or clinical researcher. All information provided is not intended as a substitute for the advice of a physician, therapist, nutritionist, or any other qualified healthcare professional.